Good morning. My name is Rush. I'm going to give my third lecture in 8 days. We're so excited. Wanted to give a big shout out and thanks to the EMCCM team, Doctors Behrens, New Payne, Briggins, D'Souza, Kim, and Beta for helping me out with this. So imagine your CCT, you get a notification by EMS for seizures for a 23-year-old female. EMS arrives, you have a 23-year-old female patient, about 32 weeks pregnant, hadn't been feeling well for about 1 day, and she subsequently had a seizure witnessed by her partner. By EMS en route, her blood pressure was significantly elevated to more than 200, and she was 800 times 3. The image sheet was not available, and so other vital signs were not documented. En route, she had 2 additional seizures, and afterwards, she was confused and agitated. She only received 2 grams of mag sulfate to the hospital. In the ED, she arrived around 5 a.m. Her ABCs were intact. She was agitated, not following any commands or for answering any questions. There's no obvious trauma, and it's pretty obvious that she was pregnant. Vital signs here initially, she was tachycardic to 140s. She's breathing rate of 26. Blood pressure was 210s or 140s, afebrile. Her O2 sat was 100% on 15 liters non-rebreather, and the glucose was fine. Of note, there's no documentation of her ever being hypoxic either by EMS or by the ED. And it's unclear why the 15 liters was placed, but she was on 15 liters non-rebreather nonetheless. So with this, is anyone to show some preliminary problems? Good. Seizures, altered mental status, anything else? Perfect. Yeah, so patient has seizures, altered mental status, tachycardic, and hypertension, and as was mentioned, all the context of this patient being pregnant. So initially in the ED, the patient was put on the monitor. She received 6 of Versed IV, and Versed was chosen because it apparently was the quickest medication that they could obtain. They gave an additional 2 grams of mag sulfate, so the patient at this point got 4 grams total in a liter of fluids. Upon more information from the partner who was at the bedside, she was 23 years old, about 32 weeks pregnant, her first pregnancy, and she had multiple seizures that day. She wasn't feeling well. She told her partner that she was feeling quote unquote blind. Partner went outside to move the car, came back, found her on the floor, and then she had a seizure, lasting about a minute, but then she soon returned to baseline. Additional information was not available due to her altered mental status. On exam, she was agitated, she was combative, and she was not following any commands. Her head and neck exam, there was no significant trauma. There was a little erythema to the forehead, but no significant bruising. Her pupils were equal and reactive. Her heart and lungs, she's not in respiratory distress. It was normal effort, and the lungs were clear to auscultation bilaterally on initial presentation. She was tachycardic, and she had good pulses throughout. Her abdomen was soft, non-tender, and like I said, she was gravid. Her extremities, she was warm, well perfused. There was no pitting edema, there was no rash, and nothing abnormal on her lower extremities. Most notably was her neuro exam. She was moving all her extremities, but she was not responsive to verbal questioning nor following simple commands. She was agitated and required multiple nurses to hold her down. She had a right-sided gaze deviation. And so with this, I just want to sort of go through, what's on the differential right now if you're taking care of this patient. Good. Anything else? Roz? Good. Good. So eclampsia is definitely on the differential. We want to think of status epilepticus and priming seizures. Also want to think of cerebral venous thrombosis, intracranial hemorrhage, or even a ischemic stroke. Press is of a concern given her elevated blood pressure. And then this broad differential of either metabolic or toxicologic is back of our mind. Think of meningitis possibly, and trauma. After half an hour, the patient still remained significant hypertensive. She was 250 or 200s. She was tachycardic to 130s, to Kipnick, satting 100%, still on 15 liters, non-rebreather. Her mental status remained unchanged. At this point, the team gave her 4 milligrams of Ativan IV over the next 40 minutes. Despite this, she still remained agitated and altered. At this point, the decision was made to intubate, and RSI was used with propofol and SUX. They used propofol because of the concern for post-seizure psychosis versus change of mental status in the setting of seizure. And so they effectively treated her in a status epilepticus-like fashion. Sorry? And as Dukas mentioned, also with help with the blood pressure as well. And these are the vent settings that were placed by the team initially. And so this was the initial VBG that was obtained after the patient was intubated. Does anybody want to interpret this? Any junior? 5 juniors here. I'll choose one. Metabolic acidosis, great. So when interpreting this, we have to keep in mind this patient is pregnant, right? And so respiratory mechanics do change during pregnancy. You have an increase in minute ventilation, and as a result, you'll have mild respiratory alkalosis. You expect the pH to be about 7.45 or so, the PCO2 to drop down to about 30, and the bicarb to drop down as a compensation mechanism to about 20. Here, we see that the patient's acidotic, not alkalotic like we expect. Her PCO2 is a little higher than expected, and the bicarb a little lower than expected. In the context of the elevated lactate, that clinical picture is consistent with the metabolic acidosis. Besides the VBG, what else would you guys want to order for this patient, labs-wise? Okay, type and screen. Any labs, any imaging, any consults, anything at all?
Look for help. The analysis, the
Good. So these are all the things that were ordered from the primary team. I got the CBC, the comp, all the pregnancy labs, CT head, and maxillofacial. Of note, they ordered the CT maxillofacial because it's forehead erythema. They were concerned for maybe some trauma, but they didn't see anything that looked like a significant deformity. And OB and neuro were also consulted off the bat. That's going to be a beta check and trend in a couple days. The results. So initial labs, they were notable for leukocytosis, about 20s, but otherwise they were mostly unremarkable. Her electrolytes were okay. Her creatinine was fine, 0.7. Her LFTs were also fine. A little hypophosphatemic, but nothing of significant concern. Her other labs were concerning. Her LDH was elevated, uric acid was high, urine protein was elevated, and urine protein to creatinine ratio was 4.75. She was COVID negative. And her point of care ultrasound showed that her fetal heart rate was normal, about 140s. X-ray that was performed in CCT showed a fluid overload concern, just blunting of the claustrophrenic angles and this prominent pulmonary vasculature. And then the knock-on CT was performed as well. Let me see if this will. It's a little difficult to see on the screen here, and even when I was looking at the on-epic alone, it's difficult. But yeah, per radiology, they read it as hypoattenuation along the right frontal, parietal, and occipital lobes, and the findings were consistent with PRESS. All right. So in summary, we have a 23-year-old female, approximately 32 weeks pregnant, is complaining of blindness for 1 day, was witnessed to have 3 seizures en route. Now she's altered. Her chest X-ray shows that she's fluid overloaded. Knock-on head CT shows hypoattenuation in the right side. And this is the new updated problem list. Eclampsia was made on diagnosis via the seizures that she had. Pulmonary edema was diagnosed between the chest X-ray and the fact that she started having increased frothy sputum prior to her being intubated. And PRESS was diagnosed based off of the imaging findings. So after she was intubated, the patient was started on her propofol drip. Nicardipine was started for blood pressure management. Despite this, she still remained hypertensive and tachycardic, and so Versa drip was soon started after with resolution and improvement of her tachycardia. And then mag sulfate was also started at 2 grams an hour. Any questions? Or OB was consulted, and they recommended steroids 12 milligrams for fetal maturation, given the fetal age. They documented that mag sulfate is usually indicated for seizure prophylaxis, is the way they put it in their note. A little too late for that, but they also mentioned that it was contraindicated in the setting of pulmonary edema. Documented in the note verbatim, yeah. Instead, they recommended Keppra 500 milligrams Q12. They also recommended neuroconsult. They wanted to admit the patient to OB for emergency section, unfortunately. Neuro came by, Dr. Pinos' team, and they mentioned they recommended to continue the trips that were already started by the team. So they recommended Lasix. They recommended Lasix for. Yeah. I'm glad that you can give this ask because I can't right now, despite how much as I want to. For the pulmonary edema, they also mentioned TTE to evaluate the cause of the pulmonary edema. ED disposition. The patient was ultimately admitted to OB for emergency section, and then afterwards she was transferred to the neurocritical care ICU. Final diagnosis. She was diagnosed with severe preeclampsia complicated by eclampsia, press, and pulmonary edema. I just want to be clear that the nomenclature used here is intentional, and there's a misconception and a misunderstanding of the clinical disease spectrum of preeclampsia, and that preeclampsia and eclampsia are sort of different processes. And so I use this nomenclature intentionally. It's something that we'll touch more about later on. So we'll talk about the pathophysiology of preeclampsia. We'll talk about its clinical effects, the complications that we see as a result of it, and lastly, the treatment of preeclampsia and its complications. So some background. Preeclampsia occurs anywhere from 20 weeks gestational age to about 6 weeks postpartum. It occurs in about 2 to 8% of all pregnancies, but it accounts for a significant portion of maternal morbidity, about 16 to 26% of maternal deaths. It's often classified as a hypertensive disorder, which is misleading. And we're going to talk more about this later on, but this unfortunately undermines its impact and severity. We care about preeclampsia because it has significant implications on both the mother and the fetus. On the fetus, it can lead to intrauterine growth restriction, placental abruption, and spontaneous and preterm delivery. For the mom, it leads to cardiovascular disease, hypertension, peripheral artery disease, cerebrovascular disease, CHF. And this is not just during pregnancy, but also a lifelong risk. And so this is something that unfortunately does not necessarily go away even once preeclampsia is resolved. This is the basic definition of preeclampsia. It's diagnosed by elevated blood pressure of either more than 140 systolic or 90 diastolic, and one of the following. Typically, it's proteinuria. There's different ways to define proteinuria, but in the ED, for us, we use the urine to protein creatinine ratio of more than 0.3. Or severe features, any one of the severe features. So elevated BP plus proteinuria or elevated BP plus one of the severe features gives you the diagnosis of preeclampsia. Now let's go through the complications that we see. HELP and liver rupture are common complications, and the incidence is anywhere from 1 to 20%. It occurs about 1% of all pregnancies, and patients with severe preeclampsia have 20% of risk of HELP. The incidence of liver rupture is a little less, fortunately. It's about 1 to 40,000 to 1 to 2.5 million deliveries. Eclampsia occurs in about 1.9 to 3.2% of patients with preeclampsia. The incidence of press is unknown because it's a radiologic, it's diagnosed by imaging. And so as a result, if you don't get imaging, you might not know how, you won't know if it's there or not, but you obviously only get imaging if you're concerned. And so for patients with preeclampsia, they found the risk to be about 19%, but if somebody has preeclampsia with neuro symptoms, headache, or change in vision, then the incidence is higher, more than about 95%. Pulmonary edema can occur with preeclampsia about 0.6 to 5%. Renal failure, so wide range. Usually it's about 1 to 7% according to the literature, but if you have severe preeclampsia or HELP, it can be up to 40%. And lastly, DIC. So the way that we're taught to classify and understand preeclampsia revolves around the blood pressure, and it uses it as a diagnostic tool and a screening tool. However, during this presentation, I want to be a challenge and revisit this classification. It's misleading and undermines the pathogenesis and severity of the disease. But it's not our fault because this is how it's often taught and how it's often presented to us, as evidenced here by the Canadian Journal of Cardiology. And it's also possible to have the other complications of preeclampsia with a normal blood pressure. You can still have PRES with normal blood pressure. You can have DIC, you can have HELP. And so the blood pressure alone isn't the most sensitive. Fortunately for us, the blood pressure tends to be elevated, so it's a good screening tool, but just keep in mind that it's not the defining thing of preeclampsia. So the pathophysiology of preeclampsia, it revolves around the idea that it's due to abnormal placentation. And so better understand this, we had to talk about the pathophysiology, and I apologize for triggering step 1 related studying. So normally the fetus implants the myometrium. There's invasion of the fetal trophoblast into the decidua, and this allows for normal growth of the fetus due to being able to receive nutrients and oxygen from the mother. Although the process is not exactly understood why, there's a theory that for some reason that the placenta doesn't invade as deeply. Whether this is due to fetal factors, maternal factors, environmental factors, it's unclear. The abnormal placentation effectively means that the trophoblasts don't invade as deeply, but rather they're more superficial and proliferative. This causes relative ischemia, and the fetus doesn't see the same amount of nutrients or oxygen as it should see. Due to the ischemia, there's a release of a multitude of factors from the fetus. Now, I don't go through this in detail. I know it's sort of complicated, but sort of the big picture of things. The abnormal placentation triggers a release of factors by the fetus and the placenta, which leads to a cascade of events, which results in what we know as preeclampsia. Fetal hypoxia leads to release of hypoxia-induced factor 1 alpha, 2 alpha, anti-angiotensin antibodies, SENG and SFLT, which are all these different basically pro-inflammatory and anti-angiogenic factors. I believe that abnormal placentation occurs early on, about first trimester, and then the clinical effects that we see occur more in the second and third trimesters of pregnancy. So the systemic pro-inflammatory and angiogenic factors causes the impact on a multitude of systems. In the vascular system, we see it leads to vasospasm and vasoconstriction. In addition, it leads to endothelial damage, which causes capillary leakage. In the liver, we see vasospasm and pro-inflammatory agents, which leads to periportal ischemia and necrosis. This results in the liver injury and dysfunction, which can cause elevated LFTs and PT-PTT. In the kidneys, we see glomerular endothelial cells being injured due to vasospasm and vasoconstriction. And there's also increased vascular permeability. This leads to the proteinuria that we usually see when we're trying to diagnose preeclampsia. There's also increased sodium and water retention, which leads to edema, as well as a decreased colloid pressure in the vessels. We see increased uric acid due to increased reabsorption in the kidneys, as well as renal ischemia, which leads to increased creatinine. In the brain, we see vasogenic edema and leaky vessels, as well as a breakdown of the blood-brain barrier and relative ischemia, which causes from the vasoconstriction, which leads to the visual changes and headache. In the lungs, we see leaky vessels and decreased vascular colloid pressure causing the pulmonary edema. And then lastly, hematologic, due to the release of the cytokines and the factors from the pro-inflammatory state, we see platelet aggregation being caused. We see consumption, which in turn leads to the microangiopathic hemolytic anemia. This leads to the elevated LDH as well, and the low hemoglobin and low platelets. As a result of this, the impact on a variety of organs, we see the clinical presentation from what we know as preeclampsia, which is effectively characterized by a pro-inflammatory and angiogenic state. We see hypertension as a result of vascular vasoconstriction and renal sodium and water retention. We see eclampsia as a result of the vasogenic edema in the brain, the leaky vessels, the breakdown of the blood-brain barrier, leading to edema and ischemia, and hence the subsequent seizures. With HELP, we see HELP as a result of the platelet aggregation, the hemolytic anemia, and the hepatic ischemia. We see liver rupture as a result of the local hepatic ischemia, which causes bleeding, which can cause subcapsular hematoma, which can eventually burst and rupture. We see renal failure as a result of vasoconstriction and glomerular deposition causing worsening kidney injury. We see pulmonary edema as a result of the leaky vessels and decreased blood pressure. We can see PRES as a result of hypertension, vasogenic edema, and breakdown of the blood-brain barrier again. And lastly, we see DSC as a result of the release of the pro-inflammatory state and endothelial damage, which releases factors which causes a cascade of events leading to DSC. So with all this as a backdrop, we come to understand that the systemic nature of preeclampsia is more than just about the blood pressure. All we care at the end of the day is how do we treat these patients in the ED. So that's what we can review here. So when we have patients of concern, once again, in that 20 weeks to 6 weeks postpartum, our goal is to evaluate these patients and screen them for preeclampsia. The diagnosis is made based of clinical symptoms, the vital signs, urine, blood, and imaging. But not everybody needs this. You can use the blood pressure to screen the patient. If the blood pressure is high, more than 140 systolic or 90 diastolic, then we definitely recommend the urine and the blood, and only get the chest X-ray and non-head CT if there's only symptoms concerning for it. If the blood pressure is normal, you can just get away with a screen for symptoms, looking for pulmonary, headache or visual, abdominal pain, or bleeding signs. Otherwise, there's no need to necessarily jump to labs for these patients. In terms of treatment, if a patient has normal vital signs and there's no concern for preeclampsia, you can discharge them back home with OB follow-up. Obviously, we care more about the patients that do have these concerns for preeclampsia, so we'll review the treatment for preeclampsia, severe preeclampsia, and complications. When I mention preeclampsia, I mean the non-severe, uncomplicated preeclampsia going forward. Any questions so far? I know it's a lot. Great. So for preeclampsia, we care about treating these patients because it's a risk of associated morbidity and mortality for both the mother and the fetus. Like we said, it can lead to premature delivery, placental eruption for the fetus, as well as maternal complications, including the hepatic rupture, DSE, and death. So there's no great treatment for preeclampsia, and the most that we can do really is prevention. This isn't really much for us to start, but there is evidence of using aspirin prior to 16 weeks of age. All this usually started by OB. And high risk means history of preeclampsia, multiple risk factors already being a vasopath, etc. For us, all we really want to do is it's really supportive and watch and wait for a benign preeclampsia patient. You want to make sure that the blood pressure is less than 160 or 110, which if it is just normal preeclampsia, not severe preeclampsia, that's what it should be. ACOG does not recommend treatment of blood pressure less than 160 to 110 because there has been shown to be no benefit in decreasing progression from preeclampsia to severe preeclampsia. And in fact, overtreatment can cause fetal growth restriction, as was evidenced by Cochrane review. For these patients, it's really expected management until 37 weeks, as was established by the Habitat trial, commonly cited by OB. Anything less than 37 weeks, the fetus won't be as mature as it can be. And anything more than 37 weeks, you increase the mother's risk of developing complications from preeclampsia. Now, what if you have a patient with severe preeclampsia, right? And this is whether it's diagnosed on the lab, such as doubling of the creatinine, worsening of the LFTs, or pulmonary edema. So the treatment for this is based around seizure prophylaxis and blood pressure control. And this is something we'll talk about in just a second. Beyond that, it's expected management until 34 weeks now. Studies have shown, have looked at use of steroids, but there is no good evidence to say that steroids has any significant help. You can use steroids for fetal maturation, but beyond that, it won't help improve the outcome. So for seizure prophylaxis for patients with severe preeclampsia, you want to use mag sulfate. And there is an IV and IM form. IV is 4 to 6 milligram bolus, 4 to 6 gram bolus with 1 to 2 grams per hour. There's also IM form, 10 grams IM plus 5 grams IM per hour. And usually this is given with buttocks, given it's a large load. Now these recommendations come from several studies, the MACLI study being the most commonly cited by OB, and there's a systematic review of 6 studies, which includes the MACLI study, which shows that using mag sulfate decreases the incidence of eclampsia, which is a seizure manifestations of preeclampsia, by more than 50%. You should be aware that max sulfate does have some contraindications, and so for these patients, you can't use it. Now, contraindications are listed here: myasthenia gravis, hypoglycemia, etc. Pulmonary edema is listed as one of the contraindications. I couldn't see exactly why pulmonary edema is a contraindication, but there is a 1% incidence of pulmonary edema in patients that receive max sulfate in general. And so they may see it as a sort of toxicity side effect sort of complication. Now, mag tox is something that you may even see on in-service coming up soon. So to be aware of, you want to be checking the mag levels every few hours for these patients, and starts off with a decrease in deep tendon reflexes, causing respiratory depression, ultimately cardiac arrest. And for these patients, you can give Lasix and you can give calcium. And now for treating the blood pressure, the goal is to treat the blood pressure and make it less than 160 or 110. As established earlier per Cochrane review, treating blood pressure does not correlate with the disease progression. And so you only want to treat high blood pressure for ACOG to reduce complications of high blood pressure, which means reduce the incidence of CHF, MI, AKI, and ischemic or hemorrhagic stroke. And the medications here, hydralazine, labetal, and nifedipine, were recommended per a separate Cochrane review, which looked at about 39 studies and showed that these were the most efficacious and the most safe. Other medications have an increased risk of hypertension, increased risk of C-section, and maternal fetal morbidity and mortality. For patients with refractory hypertension, despite using these medications, you can use nicardipine and esmolol drips. As a last-ditch effort, if this med doesn't work, you can also use nitroprusside, although you try to avoid it because of risk of cyanide toxicity as well as cerebral edema and fetal toxicity. Of note, Dr. D'Souza had mentioned there's a medication called pheneldipan, which I hadn't heard about until looking at this, preparing for this presentation. It's something that we used to have here at Downstate. I don't know if we still have it, but it's safe and also something that can be used and has been shown to be used in case reports, but there's no strong recommendations one way or another in the literature. So now let's discuss the complications of preeclampsia, and by that I mean the progression of preeclampsia. So eclampsia is effectively the seizure manifestations of preeclampsia. These seizures tend to be short in nature, about 1 to 2 minutes, and self-resolving, with a relatively quick return to baseline. The complications of eclampsia include intracranial hemorrhage in the mother, cerebral ischemia, placental abruption, DSE, and general ischemia and anoxia. Now, I think preeclampsia is a misnomer. The term eclampsia and preeclampsia is based off of a historical misunderstanding of the disease. The term preeclampsia implies that the natural history of patients with persistent hypertension and proteinuria will lead to seizures if untreated. However, we know that's not true. Studies have shown that if you don't treat preeclampsia, only about 2 to 3% of these patients ultimately progress to eclampsia. However, on top of this, seizures occur. However, despite this, other complications can occur in these patients, even in the absence of seizures, like I said, mentioned before, including PRESS, HELP, and DSE, etc. And so preeclampsia and eclampsia can be a little tricky to understand if taken just by the way it's named. In terms of treatment, it remains the same as a prophylaxis. You still want to give mag sulfate 4 to 6 IV with 1 to 2 grams per hour IV afterwards. For refractory seizures, there is no good data per ACOG in guiding the treatments for patients with persistent seizures despite treatment with max sulfate. You can try rebolusing an additional max sulfate 2 to 4 grams IV on top of the bolus and IV that I've already given. You do this once. If that doesn't work, you can try using Dilantin and benzodiazepines, but they only recommend these medications specifically because of their use historically and their comfort with it. There's a questionable use of Keppra as well. Keppra hasn't been studied as a neuromedication, but it's shown to be safe in pregnancy in general. But at this point, if they're still having persistent seizures, it's sort of do whatever you can. And you basically treat these patients like a status epilepticus and treat them as you would. Propofol is class B valproic acid is class X. Everything else is somewhere in between. Yep, Stephanie?
Is there like a recommendation in terms of like the order in which you would give these? Like, I know you're giving mag sulfate first, but and then probably like benzos, but then would you give like Keppra versus Metformin?
So no, for preeclampsia specifically, there is no recommendation. No, it's really, you give the mag sulfate, it doesn't work. You give bolus of mag sulfate again. If it doesn't work, you can try the benzos, you can try the dilantin if you want to. You can try Keppra instead, then intubate with propofol likely. The next complication I want to review is HELP. And patients with HELP, which is hemolysis, elevated LFTs, and low platelets, these patients usually present with fibroquadrant pain, nausea, vomiting, malaise, and headaches. Of note, about 30% of these patients present postpartum, so this makes sure you have high clinical suspicion for patients that have just delivered. And there's a high rate of morbidity and mortality. If you have HELP, there's a high incidence or coincidence of other complications that we've mentioned today. Diagnosis based off of labs, as mentioned here. So the treatment is based off of patient severity and the gestational age. If the mother is crashing and dying, she needs a delivery as soon as possible. Beyond that, they recommend waiting 34 weeks until delivery. If the patient's more than 34 weeks, they will deliver then. If the mother is anywhere from 27 to 34 weeks along, they recommend stabilizing the patient and then delivering about 24 to 48 hours later. And if the mother is less than 27 weeks, they recommend expectant management because anything beyond that, less than that, the fetus is not viable. Obviously, if the mother is crashing in any of these scenarios, especially the last one, you want to deliver as soon as possible. And the other treatment is supportive care, as we talked about. The blood pressure control with the medications that we mentioned before, and the seizure prophylaxis with mag sulfate unless there's any contraindications. In terms of transfusion, something to consider, they recommend a goal of more than 7. If the patient's actively bleeding, you might want to shoot a little higher. And then for platelets, if the patient is not bleeding and they plan a vaginal delivery, you can do platelets about 20,000. If they're planning for C-section, they want to go about 50,000. Some other medications that have been studied in the past have been steroids. Per a Cochrane review of blood studies, there's no benefit of giving steroids, and so its routine use is not recommended. Plasmapheresis is a new thing. Some case reports here and there, but nothing that recommends its routine use either. A related complication to HELP is liver rupture. You get local ischemia and bleeding, and you can have a small subcastular hematoma, which can increase and eventually rupture. If it's a patient that's stable and has a small bleed, you can consider giving recombinant factor 7A. All this is likely going to be done as an inpatient setting. For a patient that has a more severe bleeding and it's rupturing, IR surgery will be your friend to help do the embolization or ligation or go to the OR for lobectomy. The next complication we talk about is pulmonary edema. And this pulmonary edema presents the way that we typically expect pulmonary edema patients to present, with shortness of breath depending upon how much fluid they have in the lungs. A study by Portis et al. Found that the majority of these patients with pulmonary edema are non-cardiogenic in nature, a little over 50%, and the other are the cardiogenic or mixed. And so the treatment for this, eventually get an echo and look for pericardial cardiomyopathy and supportive treatment. Do the give them any respiratory management, whether it's just if they're fine with room air, that's fine. Give them nasal cannula, BiPAP if needed, and eventually intubate if the patient needs to be intubated. Don't forget the blood pressure control and seizure prophylaxis in these patients with pulmonary edema. Now there's this question of, do we give max sulfate in these patients with pulmonary edema? That's something that is an official contraindication for patients with pulmonary edema. You can, I guess, instead consider either the dilantin or Valium. Sorry, yeah, Valium. And lastly, delivery. For these patients, you can manage them. If they're managed onto supplemental O2, they probably will wait until they're about 34 weeks of age. If they're less than 34 weeks and they're crashing and they need to be intubated, they'll probably deliver sooner. So you need OB's help for this as well. Just want to briefly touch upon airway management in pregnancy. These patients tend to have difficult airways because nothing in pregnancy is ever easy. They have increased upper airway edema due to the decreased collar pressure and fluid retention, which leads to difficult anatomy and poor views. There's also increased weight from the mother and the fundus pressing upwards, and so it's going to be difficult to manage that as well. In general, they recommend proper positioning, whether that means blankets underneath the shoulders, ramping the patient, putting them in a sniffing position, and pre-oxygenation. The one thing that I found was recommended for anesthesia literature is using a smaller endotracheal tube, given this concern for increased edema. For comorbidities, just be mindful of whatever else might be going on. So if they are in renal failure, they might be hyperkalemic, so be mindful of the medications that you're using. In terms of the medications, there's no good data in the literature about what you should use to intubate these patients. And the only thing that is recommended is try to decrease the hypertensive response and surge as much as possible. And then for vent management, you want to try to match normal pregnancy physiology. No great data or recommendations for that either, and they recommend an ARDSNet-like lung protective strategy. For FI2, start higher, then work your way down. Fetal ischemia and anoxia is not good. For PEEP, you can start in the 5 to 8 centimeters for water, but as the trimesters progress, you might need higher to combat the atelectasis and pulmonary edema. And lastly, for tidal volume, you want a lung protective strategy, about 6 to 8 cc's per kilogram of ideal body weight. Renal failure occurs about 1 to 7.4% of patients, higher incidence of patients with help and treatment. These patients present the same way that we see typical renal failure patients. You treat them the same way that you treat typical renal failure patients. Stabilize them, stabilize their electrolytes, stabilize their fluid mechanics. For this, you can dialyze them normally. It's interesting, there's no actually role for emergent delivery in these patients because you can dialyze a pregnant patient. The only time they'll jump to delivering these patients emergently is if there's any sudden fetal distress. Otherwise, they'll wait till about 34 weeks for fetal maturation. Press. These patients present with the headaches, the nausea, the vomiting, and change in mental status. So press is defined by white matter changes on the radiologic imaging. And BP tends to be elevated in most of these patients, but it can be normal and even mildly elevated in about 20 to 30% of cases. Of note, there is a school of thought that press and eclampsia are related. And just a thought process that either press precedes eclampsia or is a result of eclampsia, but there is an unknown, but there is a clinical overlap. So the treatment for press might start sounding familiar. You want emergent delivery. And then don't forget the blood pressure control. Don't forget the seizure prophylaxis. Of note, patients with press tend to be hypomagnesemia, so it's unclear what why that is the case, but magnesium will probably help these patients. 2 medications that are mentioned in the literature. One is steroids. The data for steroids is extremely poor. It's based off of its role in improving vasogenic cerebral edema, and it's due to mass. Its role in press is theoretical, and there's no good studies to support its role in routine use. And then for diuretics, our patient received diuretics, although it's more for the pulmonary edema. There are occasional case reports of using diuretics for patients with press. However, they also received every other treatment under the sun. And so there's a lot of biases set up here. Whether it was a diuretics that helped or not, it's unclear. And once again, no good studies to support its routine use for press, and I would avoid it. Lastly, DIC. This presents in the same catastrophic way we see DIC present. These patients need immediate delivery. And the transfusion recommendations are the same as typical DIC. There's nothing special about treating DIC in a pregnant patient. Don't forget the blood pressure control and the magnesium or any other seizure prophylaxis. And then delivery, like I said. So with this, hopefully I've impressed upon you all that preeclampsia is more than just about the blood pressure. It's an important component and it's helpful for screening the patient, but you want to keep more than just the blood pressure in mind. It's a spectrum of disease. And it can be anywhere from just benign, or what may seem as benign hypertension, to the fulminant complications of HELP, press, pulmonary edema, DIC, and renal failure. So our patient, OB got a little bit more of a history, and it turns out that she had prenatal care, but hadn't seen an OB in the last 2 months. She never had any blood pressure issues prior. She was taken to the OR emergently, and she had a C-section, and soon she was transferred afterwards to the neuro ICU. She received a mag sulfate drip for 24 hours, which is the typical course for mag sulfate. She received an MRI, which is consistent with press. Interestingly enough, she was intubated, or she was extubated the same day of admission. And this is MRI just for fun. If it loads, great. If not, we can move past it.
How do you differentiate press versus eclampsia?
So eclampsia doesn't necessarily have any findings on MRI. Yeah, eclampsia is just a seizure part of preeclampsia, and press is just the MRI findings. So that's a good question. That's why there's a question of clinical overlap. So I guess we'll. All right. So if you look on the right side, you'll see the abnormalities. Great. So in hospital day number 1, she was actually downgraded to LND. Her EEG was normal, and she started on a Keppra taper for 2 weeks. On days 2 to 5, patient was actually back to baseline. She was ambulatory. She was ANO times 3. Her labs were improving with respect to preeclampsia. Her TTE did not show any evidence of systolic dysfunction. Yeah, she had a prolonged stay mostly because of persistent hypertension. They required multiple rounds of IV meds being pushed as well as med consult to help them out. Eventually, she was discharged to hospital day number 5 with Keppra, labetalol, and nifedipine. So in summary, preeclampsia exists and presents itself on a clinical spectrum. It's a systemic disease, so keep in mind that the high blood pressure might indicate something else might be going on. Management is preventative and is based with mag sulfate or any other anti-seizure medication, as well as blood pressure control being key. Delivery is the only treatment for patients that are crashing. And OB's help will be crucial for ED and for follow-up with management. These are my references. Any questions?
There's 2 in the chat.
Yeah.
The first question in the chat was, would you still give IV now with the patient already seen?
So the question in chat was, would I still give max sulfate IV if this patient already seized? Yes, I would still give max sulfate if the patient already seized. If they had a second seizure after getting the initial max sulfate, I would still get that bolus as well. Yeah.
Magnesium is good for blood pressure. Yeah, the original calcium channel blocker.
And then the second question is, would you consider getting a CTV in addition to a non-counter rule out CBT?
So would I get a CTV? If it's a clinical suspicion for it, yes, but it wouldn't necessarily be the first thing that I jump to in the ED. If they're altered, I think doesn't necessarily go with just a CBT alone. They might have more the headache and then maybe some nausea and vomiting, but the altered mental status doesn't go with that picture. If they
I
have,
know that's such a high blood pressure.
right.
I think if you have a good explanation for the high blood pressure and you go for eclampsia or preeclampsia, nothing you have to worry about.
Yeah, as Dr. Sinner mentioned, also the blood pressure is elevated, and so that's more consistent with preeclampsia and eclampsia as opposed to CBT.
I think with the whole picture, I was worried about CTV and restriction. If it's that catastrophic, you probably actually see changes on the CT knockdown as well.
Yeah.
And then I think for the first question, Mr. Ryan, I mean, even if the patient's not seizing in front of you, it sees they have eclampsia. So you have to, it's not like epileptic seizures where it's just event and then that's not a big deal. It's a full systemic, as you presented very well. So you have to treat them that.
Great. Thank you, guys.